All right, good morning, everyone. All right, just wanted to welcome everybody to this year's first presentation of our 2026 speaker series. I wanted to thank you guys all for joining us and thank our industry partners for joining our event as well. The Nebraska Oncology Society would not be able to meet its mission without their partnership. Here is our agenda for this morning. And we also have programs up at the registration desk if you didn't catch one. Just a couple of housekeeping items. We always ask to please keep your cell phones muted throughout the event. After the presentations, we'll have time for questions, so feel free to ask our speakers. And for those joining us on Zoom, you can either unmute yourselves or put them in the chat box. We do have continuing education credits available for this morning's event. And there should be, QR codes on your tables that will have the link for you guys to be able to claim those. So for our event, we're hosting 2 presentations on the topic of HEMONC. Our first presentation will feature Dr. Rafael Bejar with a presentation on practice-changing insights and implementation strategies in lower-risk myelodysplastic syndromes. Dr. Bejar is a professor of medicine at UC San Diego Health and a nationally recognized expert in MDS. He established the UC San Diego MDS Center of Excellence, bringing together advanced diagnostics, supportive care, clinical trials, and specialized expertise for patients with MDS. As a physician scientist, Dr. Bejar leads a research laboratory focused on the genetic drivers of MDS and the development of personalized treatment strategies. His work, published in leading journals, including the New England Journal of Medicine and the Journal of Clinical Oncology, has helped advance mutation-based prognostic testing and individualized therapy selection. Dr. Bejar completed his residency at Brigham and Women's Hospital and fellowship training at Dana-Farber Cancer Institute. Welcome.
Thank you. Thanks for the introduction and for the best pronunciation of my name and an introduction ever. It's a pleasure to be out here in Nebraska. I've come from San Diego, as I said, so I got to see real weather last night. That was a treat. I'll be talking to you about lower risk MDS and optimal treatment strategies for this condition. These are my disclosures, and this activity is sponsored by BMS. So the objectives today are to go over some of the clinical trial data that supports our current paradigm for treatment in MDS, specifically patients who have anemia that requires some deal of treatment. And I want to frame this in the context of how we approach lower risk MDS patients, how we identify them, and what our goals are with their treatment. So I'll start with this concept that we have this idea that lower risk MDS patients have this chronic condition, that our goal really there is to improve their quality of life, but our therapeutic choices really haven't been powerful enough to really alter the course of their disease, just really improve some of the symptoms and maybe their blood counts for a time. But I think that paradigm is changing now. I think we're getting new drugs that may actually make an impact for these patients long term. So I'll start with what we mean by lower risk MDS. And there's, I think, increasing confusion around this, as in 2022, we updated what we call our classification scheme for MDS. In the past, we had really divided MDS into diseases based on morphologic features, how the cells look under the microscope. We have 2 categories of patients who have MDS with excess blasts, depending on their bone marrow blast number, and then a variety of categories based on patients who have less than 5% blasts in their bone marrow. And that was, again, largely based on morphology, how these cells look under the microscope. There was a category for patients who had ring sideroblasts, which are these cells that have these iron deposition around the nucleus. And there was one genetically defined category. It was MDS with del5q, or deletion of chromosome 5q. These were important patients to identify because they have a really wonderful response to lenalidomide. We wanted to make sure that these patients were captured in their classification scheme. But in 2022, we updated the classification scheme, and we started to go to a more genetically defined classification of MDS. We still had these categories of increased blasts, IB1 and IB2. And then we had new categories that included hypoplastic MDS. But that ring sideroblast category changed dramatically. Instead of being called MDS with ring sideroblast, we now call it MDS with SF3B1 mutation. And the reason for that is that there's a very strong association between that mutation and the presence of ring sideroblast. It's probably the cause of those ring sideroblasts. We maintained the MDS with del5Q, but we added a category of MDS with biallelic TP53 mutation. These are patients who have a very, very poor prognosis that is independent of their blast count. So even a low blast count patient with two mutations in this gene TP53 does very, very poorly. And we wanted to make sure we identify those patients at the diagnostic time point. There's also a category for MDS with fibrosis that's not genetically defined, but important to identify because there may be treatments that are more appropriate for those patients. Now, we had a competing classification scheme that came out at the same time by the ICC. Unfortunately, there was a good amount of overlap between these two schemes. They also defined patients who have MDS with SF3B1 as their genetically defined category, MDS with del5Q, and they included this MDS with biallelic TP53 mutation. So those tended to overlap, but there were some subtle differences between them that made it a little challenging for pathologists and clinicians to understand exactly which system they should use. There has now been proposed a kind of reconciliation or a harmonized categorization. And we really maintain those three genetically defined categories, which capture a good number of patients. Of course, patients with high numbers of blasts in the bone marrow, those patients are likely to be higher risk. So those are patients that we won't be focusing on for the rest of the talk today. Now, one of the reasons that we made this transition to more genetically defined subtypes is we have a much better understanding about the mutations that give rise to MDS. And here's a partial list of all the different genes and chromosomes that can be abnormal in this disease that can acquire mutations. And the most common mutation you see here on the left here is SF3B1, that gene, again, that's responsible for those ring sideroblasts. But you can see even it is not present in the majority of patients. So MDS is a very heterogeneous disease when it comes to the genetics. But we can use that information to help understand what risk our patients are facing when they're diagnosed with this disorder. And the old tool we used to use is called the International Prognostic Scoring System. It was very simple when it was first designed in 1997. It really just looked at whether patients had increased blasts in the bone marrow, how their chromosomes looked, and whether or not they had low blood counts. Now we have a much more sophisticated model that you can't really keep in your head anymore. You have to use an online calculator, but it takes into account all that genetic information that I just showed you. We can use those mutations to understand patients' risks, divide them into a variety of different risk groups. In this case, there's 6 different risk groups that patients can fall into, ranging from very low all the way up to very high. And they have really meaningful differences in overall survival. In fact, the difference in these survival curves look like the difference we see in patients who have metastatic lung cancer compared to patients who have stage 1 lung cancer. They range quite broadly over time. And the tool we had been using up until 2022 was the IPSS-R, which is still a very valid tool. It identifies lower risk patients very well, but there is some transition, meaning there are about 10% of patients or so who will be upstaged if you use the IPSS-M, the molecular tool I just showed you, over the IPSS-R. So I think the IPSS-M can now be considered the gold standard for how we assess risk in patients with MDS. And that's the tool that I use to help identify which patients have lower risk and which patients have higher risk disease. But it's not the only way you can do that. The IPSS-R is still perfectly valid. It'll capture that information in 90% of your patients. And the IPSS still exists and can certainly help identify some lower risk individuals. But there are some caveats. If those tools tell you that someone is lower risk, but you've already been through a couple of therapies and they've been refractory, particularly people who might have seen drugs like azacitidine or decitabine, then those patients truly aren't lower risk anymore, right? Refractory disease is not the same thing as having lower risk disease at the time of diagnosis. So as I mentioned at the beginning, the paradigm had been when we think about lower risk MDS, these are patients who hopefully have a long amount of life ahead of them with their disease, but they may be suffering from consequences of their disease. And what we want to do is address those symptoms and improve quality of life. And while that still remains an important goal, we would love to do more than that. We would love to be able to delay the progression of their disease or prevent the most negative outcomes of their disease when it does eventually become refractory to treatment. So now we're really thinking about options that might actually help prolong life, not just improve quality of life. Why do I say that? Well, when we look at lower risk MDS patients, It's true that they have a low risk of transformation to acute leukemia. It's about 16% or so in all comers, and maybe even lower than that in people with very low risk disease. But their cause of death is still related to their disease. That if we look at the cause of death in patients with low risk MDS, it's largely driven by infection or other complications of cytopenias, including heart disease, hemorrhage, and so on. AML only represents a small portion of those deaths in patients with low risk MDS. So if we can mitigate some of these other consequences, we might actually make an impact on survival. So what are the most greatest needs in patients with MDS? The majority of people with myelodysplastic syndromes develop some degree of anemia, and it may become transfusion dependent or may become just shy of that at the point where patients are already symptomatic. And that is the area that we have focused most of our therapeutic approach on. Of course, there are still people who do develop neutropenia or thrombocytopenia, and we have fewer options for those disorders, but we will capture 90% of people with anemia if we look at that aspect of their disease. And we know anemia is not a great thing to have. It certainly lowers their quality of life, but also is associated with a worse overall survival. And we need great options for these patients. So this just summarizes what those goals of therapy are, that we are looking at quality of life, but we're also now interested in looking at survival as well, delaying time to transformation if we can do that, but also targeting those comorbidities. So what do we do today? It does depend on what kind of MDS people have. As I mentioned before, MDS with del(5q) and isolated anemia respond very well to lenalidomide. Patients who have isolated anemia can get a variety of different factors aimed at increasing their hemoglobin, growth factors, luspatercept, and even perhaps now imetelstat, a new drug that has been more recently approved. And if patients do have these targetable mutations like IDH1 or IDH2, drugs that target those mutations specifically can be very effective, but they represent a very small minority of MDS patients, anywhere from 2 to 5%. The group that we really don't have anything for are those TP53 mutated patients. They respond to therapies, but their therapies tend to be their responses tend to be very short-lived. Relapse is very common, and unfortunately, overall survival remains very short. So for a TP53 mutated patient, first, they're very unlikely to be lower risk, but if I do have one, I would aim for a clinical trial for them. Now, even back in 2008, we had some data that suggested that improvement in anemia could impact quality of life and survival. And this was based on a study that looked at patients who were transfusion dependent and stratified them by their degree of transfusion dependence. And if you took patients that had a mild transfusion dependence, less than 1 unit of PRBCs per month, and treated them, in this case, with erythropoietin analogs and G-CSF, we saw that there had a difference in overall survival. It wasn't just improvement in their transfusion. It didn't change the course of their disease, the likelihood that it might become leukemia, but it did seem to make these patients live longer. And that wasn't so much true with patients that had a greater transfusion burden of more than 2 units per month. And that may be because of the limitations of EPO in that context. It can improve the hemoglobin, but only so much. So this idea was out there that perhaps improving anemia, at least in patients who are mildly transfusion dependent, could make a difference. If we had better agents, could we make a difference for a broader range of patients? So that brings me to this drug, luspatercept, that you, I'm sure, are familiar with. Luspatercept is a very unique drug in the sense that it is a receptor body. What we did, or what the folks who created the drug did, was fuse a receptor for TGF beta ligands with a human IgG Fc domain. And this creates a long-lived protein that can float around in the bloodstream, but can continue to bind those TGF beta ligands. So it acts like a mop. It mops up all the extra TGF beta that's out there and prevents it from acting on the actual receptor that sits on the surface of hematopoietic cells. And normally, those TGF beta ligands put a brake on erythropoiesis. So they slow down the production of red blood cells. It's an important tool to have as a living body, because if you need erythropoiesis to occur quickly, you can lift that brake and erythropoiesis can happen more quickly. So what we are doing is taking advantage of that endogenous mechanism and using a receptor body to release that brake and allow red blood cell production to occur more quickly. That's a mechanism that's very different from what ESAs do. ESAs stimulate the early differentiation of cells down the erythroid pathway, so they kind of feed the pipeline, and luspatercept really removes the brakes at the end of the pipeline. Now we're going to talk a lot about, again, MDS with ring sideroblasts, what we used to call RARS, because these patients have a particularly increased sensitivity or likelihood to respond to lenalidomide. And again, you can identify these morphologically, but now you can also identify the vast majority of them using a genetic test for that SF3B1 mutation. When I give this talk to the fellows, I remind them this will be a board question. So if you need to take the boards, that's a good thing to know. So how did luspatercept actually become approved? It was first tested in what we call the Medalist trial. This was a trial that compared luspatercept to placebo in patients that were transfusion dependent. So they had low risk MDS with transfusion dependence, and they have been through some form of treatment, likely with an ESA, or have an EPO level that's higher than 200, meaning that they're less likely to respond to an ESA. And that's an important number to know. EPO levels higher than 200 show lower response rates to ESAs. So these patients were treated with an injection every 21 days, and the outcomes were actually very encouraging. That we saw 8 weeks of transfusion independence, 8 weeks or longer, in 38% of patients treated with luspatercept compared to 13% of patients who were treated with placebo. And if you looked at longer periods of transfusion independence, like 12 weeks or 16 weeks, again, luspatercept was doing much better than placebo in these relapsed or refractory patients. Now, that was in the setting where patients had already been through some sort of treatment or were unlikely to respond to established ESAs. And they were comparing luspatercept to placebo in that case. But a more important question to ask was whether luspatercept was a better first-line treatment. And that was tested in this study called the COMMANDS trial, where they compared luspatercept to epoetin alpha in newly diagnosed patients. Now, that prior study that I mentioned, the Medalist study, focused only on those individuals who had ring sideroblasts, who had those morphologic features that could identify patients more likely to respond to luspatercept. In the COMMANDS trial, they did away with that requirement. You did not need a mutation in SF3B1. You did not need ring sideroblast to participate. You just had to have an EPO level less than 500. And I'll just jump to the bottom line of this study. And actually, I will not do that. I'll start talking about who we treated. So this included patients that were very heavily transfusion dependent. About 35% of patients had more than 4 units of red blood cells given over the prior 8 weeks. And these patients tended to have a range of EPO values, but most of them had EPO values that were less than 200. And as I mentioned, 200 is an important number because those patients are more likely to respond to ESAs. So the ESAs had a good chance of treating these individuals. And as I mentioned before, the ring sideroblast status, these patients, they did not all have to have ring sideroblasts, only 3/4 did. So the bottom line of the study was that COMMANDS was positive, that you had about a 60% chance of achieving 12 weeks of transfusion independence in this study compared to about 35% with an ESA alone. So this is again now compared to an active comparator and not a placebo. And it didn't seem to matter what the transfusion dependence or the transfusion burden was. If it was a high transfusion burden, patients still did better with luspatercept than they did with an ESA, although the response rates were a little bit lower. And if patients had low baseline EPO levels, they still did better with luspatercept, even though they're more likely to respond to an ESA if they have less than 200 for their EPO number. And you can see that patients who have an EPO level of greater than 200, 200 to 500, had a very low rate of response to ESAs. But there still is a dependence for luspatercept. And that ring sideroblast status made a difference here as well. If patients had ring sideroblast, luspatercept was clearly superior with more than a doubling in response rate. But if patients did not have ring sideroblasts or SF3B1 mutations, then the results were more comparable. Here in ESA and luspatercept were about equally effective. So this is the one patient population for which I will still consider an ESA as appropriate for frontline therapy. If a patient has a very low EPO value, does not have ring sideroblasts or an SF3B1 mutation, has isolated anemia, then an ESA is still a good option for these individuals in the front line. You could certainly use that. And that allows you to save luspatercept for later should that drug no longer work for them at some point in the future. Alternatively, you could start with luspatercept, and there's no problem with that either. Now, 12 weeks of transfusion independence is nice, but it's nicer to have a longer period of transfusion independence. So when you look at 24 weeks, then you can see the numbers look very similar. And then the other question to ask is, what is the duration of the response? So after patients achieve 12 weeks of transfusion independence, you start the clock and you see when is it that they require their next transfusion. And it takes longer for patients to get to that point with luspatercept than they do with epoetin alpha, although these differences are just barely statistically significant. I'll point out there are some subgroups in which it makes a bigger difference. And as you can imagine, the ring sideroblast group is the patients who actually have a much longer time on luspatercept than they do on EPO alpha after they respond. With the ring sideroblast negative patients, the differences are not so stark. We looked at a bunch of other factors, including mutation status, to see if that helped you predict which patients are going to do well or not. And there really was nothing that truly stood out when you looked at large numbers of patients, that no matter what mutations people had, they tended to do a little bit better with luspatercept than they did with an ESA in a frontline setting. And if we looked at the mechanism of action, we could see that it was not just affecting anemia, that these drugs were affecting these inflammatory markers, these TGF-beta ligands, across the board, and they were decreasing inflammation in the bone marrow, which we think is an important mediator of MDS-derived cytopenias. And they did see some improvement in other blood counts that were not just red blood cells. So we saw a slight difference in neutrophils. We saw a slight difference in platelets. Now, not all of these individuals were thrombocytopenic or neutropenic to begin with, so these differences may not be as clinically meaningful, but it's important to note that we're not just affecting anemia in this case. And if a person has borderline thrombocytopenia, sometimes you can see an improvement in their blood count there. Now, of course, with any therapy, it's important to compare adverse events as well. So the COMMAND study allowed us to compare them directly to EPO and alpha. And I'll point out a couple of differences between these two. First of all, fatigue seemed to be different, that there was a higher rate of fatigue associated with luspatercept. It wasn't high, it wasn't grade 3, 4 fatigue, but there are some individual patients who may experience significant fatigue with this drug, even though their hemoglobin is improving. It's almost paradoxical in that sense. In my experience, if you continue to treat these individuals, they tend to accommodate. This isn't something that is persistent, but in some cases, it actually has been limiting. So just to point that out, that can occur. Hypertension was the other one that I want to mention. It was slightly higher in patients treated with luspatercept, but that may be a function of improving hemoglobin. These are patients that, because of the increased blood viscosity, now have higher blood pressures. And had the ESA been as effective, that might be the case there as well. And it's easy to manage with blood pressure medications. Those are mostly patients who had pre-existing hypertension. If we look at longer term responses, like how many patients respond for a year or for 18 months, we can see that luspatercept again is superior to ESAs in that regard. You have more patients having that really prolonged period of transfusion independence that we really would like to see in our patient population. 8 to 12 weeks is nice, but not long enough, I think, to really change things. And if you look at this longer time point that now goes out for 300 weeks, so almost 6 years of follow-up, again, luspatercept remains superior to potent alpha in these individuals. One of the interesting things that started to come out with this longer follow-up is that we started to see some differences in overall survival. And it isn't something we saw early. So this isn't like treatment with chemotherapy, for example, in AML, where you see some patients respond and some patients don't. This is really something that happened much later. So this may be the cumulative effects of correcting anemia over a long period of time that leads to differences in mortality that really only emerge 2 to 3 years later. This really still needs to be, I think, verified independently, but it was interesting to see that this correction of anemia started to affect overall survival, similar to what we saw in these low transfusion burden patients treated with ESAs and GCSF many, many years ago. Now, I want to talk for a minute about dosing of luspatercept because I think this is a real practical issue. That in the study, it made it seem like the starting dose was going to be highly effective because of the people who responded, most of them were receiving that starting dose of 1 milligram per kilogram. But as time goes on, you may need to adjust the dose. Even though if a patient has achieved a remission, they can sometimes have that remission wane a little bit over time. And it should be pretty straightforward to alter the dose. We have been starting at 1 milligram per kilogram, but if a patient doesn't respond within 2 injections, when you would already expect to see a response, you can increase it to 1.33, and then you can increase it again to 1.75 milligrams per kilogram. I have had some patients that have such a robust response that we've actually lowered the dose or increased the treatment interval, but usually what we're doing is increasing the dose over time. But the question arose, well, why don't we just start at the higher dose? And if patients respond, we can titrate it down, or if patients don't respond, we'll know more quickly whether that's the case or not. So the Maxilis trial was launched to do just that, where we're treating patients with luspatercept either at a high dose every 21 days, or we're treating patients who have relapse refractory disease with luspatercept at high dose every 21 days. And what you can see in these individuals is that the response rates are even higher than we would have guessed from the command study, that the response rates are in the 70% range, and particularly in those individuals who have those ring sideroblasts or have a very low EPO level. So this is an option, especially for a patient who may have a heavy transfusion burden where you anticipate you're going to have to go to a high dose anyway. I think it makes sense to consider starting with that high dose to see if you can get them to respond more quickly. And if they don't, then you can move on to alternative therapies more quickly as well. So there's a case included in here that summarizes some of the things we talked about. A 78-year-old male with ring sideroblast positive MDS. He has transfusion-dependent anemia. He has this SF3B1 mutation we've been talking about and an EPO level of 220. So based on the discussion we've just had, what options would be your preferred for managing this patient? Would it be an ESA? Would it be luspatercept? Would it be a hypomethylating agent like decitabine, a clinical trial? Or would you continue to observe this transfusion-dependent patient until he becomes more heavily transfusion-dependent? Would you consider lenalidomide or imetelstat? I don't know if you have a mechanism for giving out answers, but I'll take anyone who wants to shout one out. You'd give a hypomethylating agent? I see. Okay. I think that for lower risk patients, we save those drugs until someone has really become refractory to treatment and they don't have any other options. And I'll give you an example of when we might use decitabine. But I think the option here is in a person who has that sensitizing mutation in SF3B1 and has an EPO level above 200, luspatercept is going to be a better option than an erythropoiesis stimulating agent or any of the other therapies that we have listed. So if we look again, after this long period of follow-up, and we look at the impact of that EPO level, we see that the lower the EPO level, the less that the body is doing to help stimulate red cell production, the more likely that luspatercept is to work. It's also more likely that an ESA is going to work, but luspatercept still seems to have a higher response rate than ESAs alone. But they both can be very effective in patients who have a low EPO level. And ESAs tend to be very ineffective in patients who have an EPO level greater than 200, and certainly for patients who have an EPO level greater than 500. So one of the questions was, might we combine these two drugs at some point in the future? And I think that is something that we're exploring now. Baseline transfusion dependence matters. If people are heavily transfusion dependent, more than 4 units in 8 weeks, and again, starting with a high dose may make sense, but luspatercept is still superior to erythropoietin analogs. And in patients who have never seen an ESA, having a higher hemoglobin is associated with this greater period of transfusion independence, as you might suspect. Now, at ASH in 2025, we saw several studies that looked at outcomes in these individuals, and we saw that initiating first-line treatment with luspatercept before a patient's hemoglobin levels fall below 8 and before they become transfusion dependent may be more effective, that it may work better in those patients who are not yet transfusion dependent. And I'll show you a study that's looking at that itself. And in real world practice, it seemed to be that luspatercept was as effective as it was in the clinical study. So you can expect to see similar response rates in your practices. So I mentioned that in these non-transfusion dependent patients, luspatercept seemed to be more effective at raising the hemoglobin. So this is something that we can now study in this Element MDS trial that's currently underway, where luspatercept is being considered epoetin alpha. But again, these are in individuals who are not yet transfusion dependent, whereas all of the studies I showed you before are in transfusion dependent patients. And the goal here is not just to increase the hemoglobin and improve quality of life, but again, perhaps by doing so, improve long-term outcomes as well. There's also a study looking at combining ESAs with luspatercept, so using this combination of the two drugs together. This is something that we tend to do in practice in patients who lose a response to luspatercept. We might be able to add an ESA to help boost that response in about 26% of patients. And when we have the data, I think we'll have more data to support that. Now, I want to go back to what we've done before with lenalidomide. As I mentioned, lenalidomide was really effective in these patients with deletion 5q or deletion with 5q and one additional abnormality. And in some of these individuals, not only did their hemoglobin get better and their other blood counts improve, but we saw that the burden of mutated cells went down. that we could identify patients who achieved a cytogenetic response. We did a karyotype, and that del5q was gone, essentially, at least to the level of the karyotype resolution. And when we looked at those patients, we saw that they lived longer. They did better in the long term if they had this cytogenetic remission. So this idea that if we reduce the burden of disease with treatment, not only do we get the benefit of improving their cytopenias, but we may also alter the natural history of their disease and actually improve their overall survival. So with this data in mind, several groups started to look at whether we might do something like we did with luspatercept, namely study it in patients who are not yet transfusion dependent and affect long-term outcomes. And this gave rise to the CintraRev trial, where they added lenalidomide to del5q patients with MDS who were anemic, but who were not so anemic as to require transfusions. And by anemic, they meant any hemoglobin less than 12. And normally you wouldn't really think of giving lenalidomide to a patient with a hemoglobin of 11 and a half, but in this study, those patients were included. The one caveat was that they didn't give the full dose of lenalidomide. They only gave 5 milligrams, and they were treated continuously on a daily basis. And this was compared to placebo in this very long study with 120 months of follow-up. And the bottom line was that giving lenalidomide at this low dose was safe and well tolerated and significantly delayed the onset of transfusion dependence in these patients that were not yet transfusion dependent. In placebo-treated patients, it took about 11 and a half months for patients to require their first transfusion. And the lenalidomide-treated patients, most of the patients never required a first transfusion, even after almost 10 years of follow-up. So this is a really striking difference. You are giving an active agent, and it does have some side effects, but at 5 milligrams, these are fairly well tolerated. So this is, I think, a really important paradigm now that we're thinking about treating patients earlier, that we don't want to wait until they are transfusion dependent. At that point, there already has been some harm done, so to speak. And in my practice, most patients are symptomatic well before they're transfusion dependent. Our transfusion thresholds are low enough that people really feel the impact of their anemia well before they get to that point. I'm going to skip the questions for a moment. So now I want to talk about another agent that's available to us. This is a drug that was more recently approved called imetelstat. And imetelstat is a really unique drug. It's the first-in-class drug that inhibits telomerase. So telomerase is an enzyme that keeps chromosomes long, because every time a chromosome gets duplicated, it would tend to shrink a little bit if it weren't for that telomerase that prevents that shrinkage from happening. And cancer cells take advantage of this fact. They can upregulate telomerase, and they can make sure their rapidly dividing cells keep their telomeres in place by having high levels of this telomerase enzyme. And the thought was by giving a telomerase inhibitor, we might unmask a vulnerability in these cells and cause them to die off more quickly. So imetelstat was tried in a variety of disorders, but it was tested in transfusion-dependent MDS patients who, again, had either received an ESA in the past or were likely to be refractory to an ESA because they had a very high EPO level. This drug is given as a single dose IV injection every 28 days, so fairly simple to administer, but it has some significant side effects that we'll talk about. But first, let me talk about what they saw in the study. They saw that in these relapse refractory MDS patients, that 40% of them had a really meaningful response of transfusion independence when treated with imetelstat. And that's at 8 weeks of transfusion independence, but even at 16 and 24 weeks, imetelstat was quite effective in about a third of patients. And some of these patients were very heavily transfusion dependent, as I'll show you. Importantly, that duration of response was quite long-lived, approaching almost a year for individuals treated with imetelstat. And these patients who had prior HMAs, even patients who had prior luspatercept, patients who had prior ESAs, then patients with high transfusion burden. The drug showed some immune responses. So this is early phase 1 data. So these little black dots is transfusion. This is lots of transfusions run integrated for these patients. And patients who achieve SOLR are patients who become transfusion independent. Again, with this oral agent that they take at home, they target the inflammatory pathway, which is a new pathway that we really haven't been getting very directly with other drugs that we have available. So this is another drug that's developed in this patient population, and hopefully it will be another option for patients in the future. There's some individual case stories showing hemoglobin over time for these individuals, just showing that it really is active, that it really can be active with these patients who are heavily pretreated with other drugs. So ultimately, the treatment algorithm for LPS has gotten a little complicated. The advent of these new agents, and this is a great thing. Because in the past, when we were really only one option for these individuals, we had a large number of patients who weren't really responding. So now this is a really useful tool. And just to summarize what I do in practice, identify patients with MDS, identify those patients that have particular subtypes that I think are likely to respond to particular therapies, identify new patients with thalidomide. And if they are transfusion dependent or approaching transfusion dependence, then I'll suggest a treatment that addresses their anemia. And if, again, the patient has considerable abscess for the mutation, the most appropriate therapy is going to be luspatercept. The patient doesn't have considerable and doesn't have a sensitivity mutations, then you can use either erythropoiesis-stimulating agent or luspatercept as the frontline treatment. And when patients fail, you can try to use the other drug, or you can use the combination. Then we have a screen drug NOS, which I'm reserving for patients who have been through less intense therapies. NOS has side effects that are comparable to methylene agents. It decreases their neutrophil count and the platelet count during the course of their cycles. And you need to make adjustments. So it's not as easy to give as these other agents, but it can be useful in those high transfusion burden patients who are requiring treatments. And then only at the end of that process do I really consider methylene agents for these low risk MDS patients, particularly if they have polycythemia and thrombocythemia or anemia. So again, low risk MDS practice has really changed a lot in the last few years as we've got new drugs that have been approved in this patient population. The old paradigm of entirely in quality of life, I think, is really outdated now. We can start to identify therapies that might improve the duration of life as well as quality of life. And we are getting a little bit more nuanced about how we select patients now. We select patients based on not just morphological features, but genetic features and equal levels. We should be checked from patients before starting a therapy like this. And as we get more drugs, we can consider adding the second style, methylene agents, or methylene agents to this treatment plan. So with that, I'll let you take any questions. Thanks.
Do we have any questions or nothing? Whether the metal stat or the other one that's in clinical trial that targets the IRA pathway, are there any, there's no limitation in terms of the likelihood or the specific genetics that you have to live with?
That's a great question. So when they looked at the metal stat, they didn't see any particular mutational pattern that made a big difference. It was interesting though that some of the mutation burden didn't go down, like you might see in lenalidomide treated patients. So again, hoping that means that it becomes disease modifying. But with the iron inhibitors, there does seem to be some propensity for patients with splicing factor mutations to respond. Patients may have a more inflammatory phenotype through that pathway, but it wasn't the response to limited to patients with splicing factor mutation.
So what do you do for the patient with P53 with P53 abnormalities?
Yeah, I had the same question when I heard the talks and have other speakers because I'm wondering as well. This is a really tough launch. Patients with TP53 mutations tend to have virus disease and the outset that even with a number of low risk features is slowly very, very poorly. So my number one goal for these individuals is to get the transplanted IPO. Fortunately, for many of them, can't because they tend to be older and they're transplant. But if I can get them to transplant, then the goal is to get them into particular remission and achieve prior to going to the transplant. Even with stem cell transplantation, the relapse rates are quite high. So for a younger individual, I believe 75 or institution who is eligible for transplant,
I should consider very aggressive treatment for that population, using a preventing agent for venetoclax combination for 1 or 2 cycles together with the prevention, then go immediately transplant. If that's not an option, then I don't use venetoclax because in the AML studies, it's really been shown to not help. Even in the AML population, it doesn't change overall survival, even if it increases response rates. So they're only simulating hypomethylating agent and try to put them into the deep prevention if I can. And again, focus more on quality of life measures that I don't think I can affect duration of health. But clinical trials are the always the right answer that I have.
So is the cycling your choice in that group?
So there are these data that I walked through from my friend John Welsh, who used high dose decitabine, 10 days of decitabine, and in some very high response rate, about 100%. Wasn't randomized trials, but the duration of survival seemed to be longer than you might expect for that patient population. But I really found that treatment to be very, very intensive. It requires hospitalization in the majority of patients and so on. So I tend to use decitabine in part because it's a shorter treatment schedule and have that anecdotal or the 10-day, but I tend to use it for the violence. But I don't really hesitate to use it as decitabine.
So one question, is there any role for immunotherapy or bispecifics or CAR T in this?
In the CD53 mutated patients? Yeah, I would hope that immune therapy could not the rescue there, that, maybe that's a different mechanism of killing and that you wouldn't be TB53 dependent, like far from any of these chemotherapy and targeted agents. But that hasn't been the case. CD123 directed treatments with the CAR T cells with bispecifics haven't really seemed to make a big difference in the patient population. We were hopeful that magrolimab, the CD47 targeted antibody, might be the drug to do that trick. The phase 2 data looked wonderful. And unfortunately, phase 3 data did not. So the drug is no longer developed. So we're still waiting for a good drug candidate.
Thank you.
Any additional questions from the audience?
One genetic question, speaking generally, an individual has myelodysplastic syndrome. Should direct family members be tested for some of these mutations that have been identified in the last, 10, 15 years?
Yeah, that's a great
What's to do?
Yeah, I would say that 10 or 15 years ago, it was said, animal fodder, MDS and disease, we had maybe genetically related, and 5% of those are young people. A 40-year-old MDS gene definitely much genetic. But that paradigm really changed. I think we understand that there are mutations that predisposed to MDS that predisposed to MDS when you're 65, now when you're 45. Mutations in a gene called EDS41, for example. So we think more about genetics now and MDS more globally because we learned that more genes are contributing to this disease. So I don't limit my thinking about testing family members to patients who are young or who have strong family history. I really consider doing genetic testing in anyone who is, and definitely patients who are going to transplant, but anyone who has a family history or has features that are more typical of some of the mutated syndromes. So EDS41, I think, is the big culprit. It causes an increased risk of MDS in patients who don't get the disease until much later in life.
And an mutation in
DNEX41.
EDX41.
Yeah. And it's not rare. And it's in probably 2 or 3% of MDS patients just by itself. And if you think about all the other mutation contributors to risk, it's probably about 10 to 15% of patients that will have some underlying mutation in that.
Would you do it that only one family member involved, an elderly, sort of an elderly person, and no other individuals in the immediate family have any medical symptoms or light count abnormalities?
I think if a person has a very typical MDS with no unusual features, then I probably wouldn't consider it. But if I have an older person who has mutations in DATA2, for example, which is another gene associated germline disposition, then I'll consider it. Or if I have a patient who I treat who has a ROS1 mutation, but that ROS1 mutation doesn't go away with treatment. In other words, there's no change in it. It sits there around 50%. Maybe that's a germline mutation as well. So there's certain features that you pick up on that will suggest that a patient might have a germline mutation that they were born with that contributes to their disease. So there are some scenarios where I'll test them. But certainly in a younger patient or any patient that can be taken to transplant who's going to get a related donor, when they get out looking for mutations in those patients.
Thank you. So if you identify either GATA or if you identify GATA or the other gene, what do you do with it? What do you do with those patients?
Right, exactly. So if you identify an older individual who's got one of these mutations, you're probably not going to treat them any differently. But I will say there are some small differences. The DDX41 mutation in particular, patients who look like they're going to do okay by the PSSM, but they have a high rate of transmutation in AML. But they also have a really great response that had good lineage. So I'm making more aggressive about treating older individuals with these mutations, but I think they're going to have a high likelihood of response. So there are some nuances you can use there, but mostly it matters for other people in the family. But if you identify you have a person who's got DDX41 mutations, you might start surveillance earlier, or you might avoid agents that might promote MDS, like chemotherapy and things like that, situations where you can have it.
Any additional questions for me? Great. Thank you so much, Dr. Khan.
All right, welcome back, everyone. Okay, our second presentation features Dr. Tysel Phillips with a presentation on BTKi and diffuse large B-cell lymphoma. Dr. Phillips earned his medical degree from Rush University, followed by a residency in internal medicine at John H. Stroger Jr. Hospital of Cook County in Chicago. His fellowship training in oncology hematology took place at University Hospitals in Cleveland. Before joining City of Hope, he was a clinical associate professor at the University of Michigan, where he was appointed the Maria Reinhardt de Cesar Research Professor of Blood Cancer and Bone Marrow Transplantation. Leading clinical trials into new targeted therapies is a vital part of Dr. Phillips' work. He has published over 40 peer-reviewed studies and attracted dozens of research grants. Welcome, Dr. Phillips.
Thank you for the invitation. Thanks everyone for showing up this morning. And so we'll take about a whirlwind tour over diffuse large B-cell lymphoma. So the end of the talk will focus a lot on BTK inhibitors, but we'll review a lot of the data that supports possible use of BTK inhibitors in certain settings, and also review some of the things that potentially may be impacting our practice in the next couple of years as we try to slice and dice large cell lymphoma into smaller and smaller categories. So here are my disclosures. This is to receive credit. I believe you guys saw this before. And this is to let you know that this is supported by an educational grant from AstraZeneca, hence the title BTK inhibitors. So as I mentioned, we'll basically have a brief overview of the incidence rates of large cell lymphoma, and then we'll discuss some of the ways, at least diagnostically, how we approach large cell lymphoma, specifically discussing cell of origin, and then some of the other more specified subsets that will likely be down the pipeline at some point, and how we can likely apply that into clinical practice and what that may mean for treatment options for us when we see these patients. So if we do a brief introduction, this is fairly a standard slide, just basically showing the incidence rates of diffuse large B-cell lymphoma. As you can see, it is still the most common lymphoma subtype within the US, Western Europe, and worldwide. This slide here also includes plasma cell dyscrasias like multiple myeloma, normally not included on the slide deck for lymphoma, but ideally you can see that large cell lymphoma is about 25% of the cases. So again, by far the most common lymphoma we'll probably see in clinical practice. So I think for the longest, we've had this knowledge of cell of origin, meaning the differences in clinical outcomes in patients between germinal center and non-germinal center. And for several years, there was a lot of work focused on NanoString, which was basically cell of origin, looking at germinal center versus the activated B cell subtype. Because again, as we do know, Han's algorithm sort of separated by IHC, but it does have about a 20% discordance versus what we would have from NanoString. Now, in the last couple of years, there's been a pullback, at least within the US, where nanostring has not necessarily been a focus, and a lot of our clinical practices have just mostly relied on immunohistochemical staining. But to that point, again, we do typically expect that germinal center patients have a better outcome than those with a non-germinal center phenotype. Now, some of that is contributed to the fact, at least with the non-germinal center patients, that includes a group we refer to as double expressors. And we do know outside of the germinal center patients, we have a carve out for double hit lymphoma, both of which have impacted clinical outcome in this patient population. So as I mentioned, if we look at the error rate with the Hans algorithm versus nanostring, or looking at molecularly looking separate into cell of origin, you can see that there's some discrepancy where IHC may call the patient germinal center, but if you were to do nanostring or molecular testing, with this is LymphGX, Lymph2CX, you can see that it would pull out a small proportion of those patients from germinal center to the activated B cell subtype and vice versa. Some non-germinal centers will then fall into the germinal center category, but we still also have a category of unknown and unclassified patient population where they don't fit well within either category. Now, to the far right, you'll see some distribution with FISH. For the most part, FISH testing isn't very helpful when it comes to distinguishing between these two different subtypes, other than pulling out patients who may be double hit lymphoma. Now, speaking of double hit, more recently, we do know that BCL6 has been sort of pulled out of the algorithm for double hit lymphomas. So this specifically refers to patients with c-Myc and BCL2 translocations, and the so-called triple hit lymphoma is really not necessarily a thing any longer, nor should BCL6 and c-Myc itself be considered a double hit. And these patients traditionally now can be treated with more standard treatment versus dose adjusted EPOCH in some situations or more aggressive chemotherapeutic regimens. So this next one sort of adds in more sort of these new testing mechanisms I mentioned. So we have LymphGen classifications, you have the DLBCL clusters, and some of the genetic hallmarks you see that help distinguish some of these situations. So specifically here, you see with the germinal center-like, you see a lot of epigenetic modifiers of EZH2, KMT2D, CRED-BP, EP300. A lot of these sort of speak to chromatin remodeling and how they may sort of lead to the development of the germinal center phenotype. Now, if we look at the activated B cell subtype, a lot of these mutations or alterations we see appear to impact the B cell receptor and lead to more chronic activation of the B cell receptor. Now, if we look at the LymphGen classifier, you see they can separate at least the germinal center into EZB, SC2. We have the unclassifiable, which is BN2, and then we have the activated B cell subtype, A53, N1, and MCD. Another sort of classification system of DLBCL clusters, as you can see, separates into C1 through C5. But again, as you can see, there's some discordance between these sort of separated tools that are separating the large cell lymphoma into different categories. Again, letting us know even today, we still struggle to adequately stratify all these patients into appropriate categories as we kind of try to sort of figure out more appropriate treatment options based on some of these mutations and molecular alterations. And again, if we look at the bottom, what we assume to be sort of the pathways of dysregulation with these mutations, PIK3 signaling, cell migration, immune cell interactions, JAK-STAT signaling, Notch2, immune evasion, genetic instability, as we see with p53 mutations, NF-kappa B activation, and then B cell receptor and NF-kappa B signaling here in this category. So the whole purpose of this sort of separation and slicing up the pie is to hopefully improve clinical outcomes and to try to see if we can actually find appropriate sort of treatment options in this sort of R-CHOP plus X model that has become sort of the new sort of go-to when we try to treat patients with large cell lymphoma. So as you can see, we have the typical sort of cell of origin, ABC, germinal center unclassified. And if we look at some of these other stratifications, MCD, N1, A53, BN2, ST2, MYC positive, MYC negative versus ECB. You see some of the treatments that have been explored in some of these variations to try to see if we can improve outcomes. Now, to the right here, you'll see that despite what we know, we do know that some of these things seem to be more impactful for overall survival. Again, looking at Notch, B-core, and NF-kappa B alterations with a 20% overall survival. And again, we see NYD88, L265P mutations, again, with a 40% overall survival. And then P53 mutation deletions and aneuploidy with 63%. And then with these, again, epigenetic modifiers with a 48% overall survival. So again, letting us know that there are room for improvement with just a traditional R-CHOP model. And again, hopefully with some of these R-CHOP Plus, which has been sort of the driver for a lot of clinical trials that we've had conducted in the last 10 plus years. So again, in your clinical practice, like my own, I think most of the times we're just doing Hans algorithm, for high-grade B-cell lymphoma. So at least patients are getting a c-Myc checked to see if that is actually altered and then followed up with a BCL2 alteration. Again, key 67 here, IAC, P53, mixed staining. Again, P53 for the most part, unless you do a mutational profile, so that's something that may not be pulled out in a lot of our traditional sort of models. And to date, we still don't necessarily have an appropriate treatment for P53 mutated large cell lymphoma. So it's a test that we can get, but not something we can actually have an actionable sort of treatment for in this situation. The double expressors, well, the patients have high expressions of BCL2 and c-Myc. And again, we all know about double hit lymphoma, but specifically, again, as I mentioned, BCL6 is not considered to be part of this category any longer. So again, if that is included in your sort of treatment algorithm, that's something that typically, again, you don't consider that to be a double hit lymphoma as of today. So briefly, if we can just, how is your site sort of diagnosing and managing the diagnostic criteria of large cell lymphoma? Is there anything different from what we discussed that you're doing in your standard clinical practice? So if anybody just for you, yeah. So is anybody still using nanostring at this point in their clinical practice, or is everybody just specifically sort of wash that away and act like it didn't exist? Yeah. So I think outside of Canada, again, nobody's really using nanostring at this point. So again, the whole purpose of this is, can we beat R-CHOP? So again, the whole paradigm at this point is the R-CHOP plus X model that we have. As you see, we have intensity, density. So R-CHOP 14 really didn't have a lot of legs. Dose-adjusted epoch R, again, in the randomized clinical trial, we had a cooperative group. It did appear to be a trend toward benefit in patients with very high IPI scores, but as a whole, it did not necessarily revolutionize frontline treatment for large cell lymphoma. Same way with consolidation with stem cell transplantation in patients with high-risk features, that as well did not necessarily seem to take on, and that's not something we typically do in our clinical practice. So some of these other models and sort of treatment algorithms have been explored in the US and Europe, but for the most part, R-CHOP had been the standard of care for several years. Now, if we look at immunotherapeutic options, don't necessarily consider polatuzumab a immunotherapeutic drug, but it's included in this category. But we have tafilin. So we do know that the frontline study will be reported out this upcoming ASCO meeting. So we'll see if that's an improvement over R-CHOP. We have bispecific antibodies. Rumor has it that at the European Hematology Associated meeting, which will happen in 2 weeks, we'll have a readout of the epcoritamab R-CHOP clinical trial. So we'll see how that compares. And then obviously we have CAR T-cell products. We have Zuma-23 in patients with high-risk disease with consolidation with CAR T-cell therapy. And allogeneic CAR T-cell therapies are more so been shifted to consolidative approach because of, unfortunately, they have not necessarily had very durable responses compared to auto CARs. Maintenance therapy has not really shown to be very beneficial within diffuse large B-cell lymphoma, even though there's some data with enzatorin in this situation that suggests in a very small subset it may be beneficial. And then we have a lot of negative studies with Velcade, ibrutinib, lenalidomide, and venetoclax in patients with large cell lymphoma. And as an aside, since AstraZeneca is supporting this, we will be talking about acalabrutinib and some of the studies that have been explored with this in upcoming clinical trials. So as you can see, the evolution of standard of care, there's a lot more red than green. So what that means in this clinical practice, we've had a lot more negative studies with trying to beat R-CHOP than positive studies. As of to date within the US, obviously Polarix is probably the only study causally considered to be positive. But I'm sure as you've heard one of the debates, there's a lot of question marks of who to apply the Polarix data set to. And is it just specifically for patients who fall into the non-germinal center subtype, or is it something you can use generally across the board? So this is a study designed for Polarix. As I mentioned, it took patients with IPI 2 to 5, randomized patients 1-to-1 to R-CHOP or polar R-CHIP, with the overall aim of improving the progression-free survival in this patient population with secondary endpoints looking at overall survival. Also, key point is that with all European studies, there's always an extra 2 cycles of rituximab. So remember that will be a key point in some of these other studies. So as we do know, the study did meet its primary endpoint. So there was a progression-free survival benefit to polar R-CHIP versus R-CHOP in this patient population with a delta of 6.5%. Side effect profile was fairly reasonable, but we do know there's an increase in neuropathy and GI toxicity with the inclusion of polatuzumab. And again, some of the big things that came up from this clinical trial is increased cost. Polatuzumab by far is more expensive than vincristine. And so again, justification for a risk sort of cost benefit, again, has sort of spurred some of the discussion and conversation we have, especially when we look at cell of origin. So again, looking at disease-free survival, this as well continues to support polar R-CHP in this patient population. But as a whole, overall response rate and complete response rate were fairly similar between the two. But again, if we look at patients who died from their disease, again, far more patients died with R-CHOP than died from polar R-CHP with a hazard ratio of 0.7. So about a 30% reduction in the risk of death with use of polar R-CHP in this patient population. So one of the biggest sort of knocks on the study also was there was no overall survival benefit. So even with further follow-up, with the more recent follow-up being over 5 years, we still don't see an overall survival benefit with polar chip versus R-CHOP. Now, an assumption is if you have a progression-free survival benefit, this should translate to an overall survival benefit, but this has not yet happened. And again, some of this you could account for improvement in second-line treatment options with the advent of CAR T-cell therapy and introduction of bispecific antibodies. But even in countries where CAR T is not accessible, we still do not necessarily see an overall survival benefit between these two treatment regimens in this patient population. So again, still an unanswered question about why there is really no big difference between the two. Now, if we look at subgroup analysis, which is a major important part for this study, even though it's not powered for this, we do see that it appeared to be younger patients that seem to do equally well with polar R-CHP and R-CHOP, patients with low IPI scores. And again, the biggest question is patients with cell of origin. There did not appear to be any benefit between polar R-CHP versus R-CHOP in patients with germinal center large cell lymphoma. Now, this sort of plays into the part of, again, the question of polatuzumab and cell of origin. Is this specifically a drug that should be used in patients with non-germinal center or activated B cell subtype? As you can see, multiple clinical trials indicate there's a significant benefit in patients with ABC, diffuse large B-cell lymphoma with polatuzumab versus the germinal center subtype. Again, supporting again that potentially there's some mechanism of action that is more efficacious in patients with an ABC subtype versus the true germinal center subtype. And again, partially explaining maybe what we see in the Polaric study and why R-CHOP is equally effective in germinal center patients. So again, this is still a great debate, something again, the company itself would try to argue that again, given that we don't use nanostring any longer, and we do know about that 20% error rate, is it better to err on the side of caution and give everybody polar R-CHP for those 20% of patients we may miss with the Hans algorithm? Or as in most patients' clinical practice, they are specifically setting polar R-CHP for patients with non-germinal center subtype and using R-CHOP for patients with the germinal center subtype. So this is an argument that will probably proceed and continue on for quite a bit of time. Maybe a moot point with some of the studies that are reading out in the summer in the next several years, but as of right now, this is sort of what the big debate is. Now, Genentech also looked at this so-called dark zone lymphoma. So they looked at another subset within a subset to sort of see if this dark zone signature can identify another patient population that may be more beneficial to patients with polar R-CHP. As you can see, this is something that most of our pathologists are not doing. So again, it's a situation where this is a very interesting academic test, but the clinical implications are a little bit limited because again, these are not something any of us can just call a pathologist and get results for. But if you look at this results, it does indicate again, polar R-CHP has a significant benefit in these dark zone signature patients compared to patients who receive R-CHOP. Now, the one big twist of this dark zone signature is something that's typically pulled out of patients who have double hit lymphoma. And as we specifically discussed previously, R-CHOP, polar R-CHP, neither one seemed to have a very significant response in patients with double hit lymphoma. There was no significant sort of efficacious benefit between the two in patients who are known to have double hit lymphoma. And so this is a bit of an odd situation where you have this carve-out caveat that appears to be better with polar R-CHP, even though as a whole, polar R-CHP did not necessarily seem to be very effective in patients with double hit lymphoma. Again, as I mentioned, in a more standard clinical practical standpoint, this is not really something most of us can use in a clinical practice. And even in the country that is actually sort of exploring dark zone signature, which is Canada, they typically use R-dose adjusted EPOC for this patient population. They're not using polar R-CHP. So again, for us who actually don't use dark zone signature, the easiest thing in this situation to remember is that patients with double hit lymphoma probably need a more intensive treatment regimen such as R-dose adjusted EPOC, as which most of us are doing in our clinical practice. And this sort of academic venture is probably not for, is pretty much for naught. As again, I don't know any of us are going to sort of say that we're going to use our polar R chip in the patients with double hit lymphoma based on this data set. So another clinical study which will sort of evaluate the benefit of polatuzumab in patients with an ABC subtype or non-germinal center subtype. So POLARGO was one of the multitude of studies we saw last summer and the summer of comparing studies to R-GemOx. Now, again, this is all looking at patients in the second line setting where, again, in a certain situation, the patients with relapsed large cell lymphoma, the use of R-GemOx is an appropriate treatment regimen. But for patients who have primary refractory large cell lymphoma, we do know that these patients specifically should probably be taken to CAR T cell therapy. And these are patients we're not necessarily using R-GemOx for curative intent. But here we have a situation where you have patients getting polatuzumab plus R-GemOx versus R-GemOx, again, in the second line setting. Again, there's randomized 1-to-1 with patients up to 8 cycles of treatment with each regimen. So the primary endpoint from this clinical trial was overall survival. What we can see is there was an overall survival benefit to patients receiving polar R-GemOx versus R-GemOx in this patient population, 19.5 months versus 12.5 months, and a 24-month overall survival, 44% versus 33.2%, with a very significant p-value, so specifically a 40% reduction in death in this patient population. Now, the rates of grade 3-4 adverse events were similar between the two groups, but again, higher rates of thrombocytopenia infection and neuropathy with the polatuzumab R-GemOx regimen in this situation. Now, I'm sure a lot of you are saying, okay, well, who's really going to use this regimen? That is a very good question in certain situations, given the plethora of other options we have here within the US. But in countries where R-GemOx is the only other option, this potentially could be an effective salvage regimen, especially if patients aren't getting polatuzumab in a frontline setting. But more specifically for this exercise here, what we can see is that it appeared that polar R-GemOx was better than R-GemOx across the spectrum. So patients with germinal center subtype, ABC subtype, unknown and unclassified, suggesting potentially that there may be some sort of synergistic potential between these two molecules, meaning polatuzumab and chemotherapy in this situation that is agnostic to cellular origin. So specifically, you don't necessarily have to use this regimen in patients only with a non-germinal center subtype. So the takeaways from this is that it did meet its primary endpoint. And again, the data, the subgroup analysis suggests that cellular origin was not necessarily specific for polatuzumab being beneficial in non-germinal center patients versus germinal center patients. And so again, this is one out of many studies to suggest that maybe polatuzumab isn't necessarily subtype specific. But again, the litany of data that we have really supports that polatuzumab probably has a better efficacy in patients with a non-germinal center ABC subtype, regardless of what this one clinical trial has shown. Now, shifting gears a bit to what all of us probably struggle with, trying to treat large cell lymphoma in older patients. Again, given that we don't typically have a true standard of care. Now, we know we have R-mini-CHOP in this patient population, but I'm sure none of us are going home sleeping well at night treating our patients with R-mini-CHOP. And looking at some of the SEER database and sort of what is being used for patients who are older than 80, as you can see, there are far not a lot of patients who are just being observed, meaning not given any treatment at all. And then you have a litany of other sort of treatment options here, so CVP, R-CVP, CHOP, R-CHOP. Again, much less than what we see in patients 66 to 80. Again, so we're choosing not to whether patient's fitness or sort of lack of sort of robustness to receive chemotherapy. Choices of outside of the standard of care are what we're being provided to this patient population. Now, the only regimen that seems to be effective in this patient population, at least durable, with some durability of response, is R-CHOP. But the question with R-CHOP always in this patient population is, can the patient tolerate full dose R-CHOP? Which in most cases, again, we are making some dose reductions for increased tolerability in this situation. So whether you're basically starting with R-mini-CHOP and increasing doses as you can, or you're starting with some sort of variation of R-CHOP and making adjustments with the drug as you see fit. Now, one key thing to realize here is that if you can get a patient through 6 cycles of some sort of effective frontline treatment regimen, you do see that the survival sort of mirrors younger patients, again, meaning that these patients are not necessarily dying from the lymphoma if you can treat it appropriately. A lot of the differences we see in overall survival and outcomes is related to the comorbidities and other factors that may impact patients' tolerance of treatments or inability to complete an appropriate 6 cycles of treatment. So again, for the most part, we do know there are multiple frailty scores out there being circulated to try to identify who we can and cannot give full dose R-CHOP to versus making dose adjustments, meaning dose de-escalations to improve tolerance of these patients. But again, this is something that we struggle with. And hopefully, as we see more of these clinical trials that are eliminating and reducing chemotherapy, we'll have a better option to offer our patients moving forward. But again, here, just summarizing things. So again, if we look at this chart, the big key takeaway here is that if you can give these patients an anthracycline, you typically will see improved overall response rates. Even though with the pegylated liposomal doxorubicin or Doxil, you do see 2-year or PFS and overall survival that appears somewhat similar to what we would expect to see in patients who receive full dose R-CHOP. Now, the biggest difference between the non-pegylated liposomal doxorubicin and the pegylated is we don't have access to this within the US. And this one here seems to cause a little bit less hand and foot palmar erythema than what we see with Doxil in this patient population. But for the most part, otherwise, these two medications function very similar, even though the non-pegylated form has a shorter half-life than what we see with the pegylated version. So one clinical study that came out of Europe is the polar bear study. Very cute name. So this looked at previously untreated large cell lymphoma patients, either 80 years of age or greater than 75 with increased frailty. Again, this is R-mini-CHOP versus polar R-mini-CHIP. In this patient population with the primary endpoint being progression-free survival. So this phase 3 study is ongoing and hopefully will read out very soon for this patient population as far as results. But again, with the early readout, what we saw in this patient population was that, again, for the most part, toxicity profiles were similar. I mean, no difference in grade 3 to 4, but we did see higher rates of gastrointestinal toxicity with polatuzumab in this patient population. And so the question is, again, does the addition of polatuzumab lead to more dose discontinuation, dose holds, and dose delays, which we know can be a sort of impact into clinical outcome and efficacy in this patient population? Now, we do not have a full readout of the efficacy readout of this clinical trial. And so hopefully this will have some sort of readout at an upcoming Congress in the near future. So looking at CNS relapse management. So very quickly to go through this. Again, we do know we have the CNS IPI score, which identifies patients who are at higher risk for CNS relapse, which is all very well and good. We do have a modified cell of origin IPI score, which takes into account that patients with ABC or non-germinal center subtypes seem to have a higher risk of CNS relapse, as you can see from these curves. So again, you can separate patients into low risk, intermediate risk, and high risk. Now, the bigger question is with these prognostic scores, always is if we can have some sort of intervention to make a difference. Now, ideally in this situation, if you see a patient who is high risk for CNS relapse, with these IPI scores, the natural knee-jerk reaction is that you would give these patients some sort of CNS prophylaxis to improve outcomes and reduce the risk of CNS relapse. Unfortunately, what we do know to date is that despite having this information and despite intervening in these patients, it does not appear that our current mechanisms, sort of treatment summary that we can utilize at this point, are necessarily having a statistically significant difference in reducing the risk of CNS relapse. So again, in this situation, if you have a patient at high risk of CNS relapse, again, we are still offering high-dose methotrexate prophylaxis in these situations, with the knowledge that, again, the data that we have does not support that this is actually making a substantial difference. And so again, this should be a more nuanced conversation with your patients, discussing the simple fact that the information that we have clinically does not support that this is actually making a long-term improvement in sort of reducing the risk of CNS relapse. But again, at this point, a lot of times we are treating our own conscience in the situations because a lot of us do feel bad knowing that these patients may have a relapse and feeling, I mean, the very small chance that we can make a difference. A lot of times we do offer high-dose methotrexate. Now, the question about how you administer high-dose methotrexate is a very important one. Again, there's data sets where we can sort of integrate it into R-CHOP, but a lot of times this leads to dose delays with R-CHOP, meaning patients are having their cycles of R-CHOP pushed back as they recover from high-dose methotrexate. And so most cases, what we're doing is basically treating with the R-CHOP and then consolidating at the end with several condensed cycles of high-dose methotrexate to provide CNS prophylaxis to ensure that we're actually treating the systemic disease appropriately. And again, knowing what we know about the benefits of high-dose methotrexate, even if we are administering this, we're not interfering again with the true intent of trying to cure the systemic large cell lymphoma. Now, the other question comes up is intrathecal methotrexate inferior to high-dose methotrexate. Again, the data set does not support that there's any inferiority. in this situation. So again, whether you use IT chemo to sort of prevent sort of CNS relapse, or you just use intravenous high-dose methotrexate, it is up to your particular preference. But for the most part, we do know differences don't appear to be substantially, the differences between the outcomes between these two don't seem to be substantially different. And so in this situation, again, it is up to your particular preference. So shifting gears to, again, looking at BTK inhibitors in this patient population. So a lot of us have already seen this kinase map, demonstrating the signaling pathway from the B cell receptor and the interplay between, again, BTK receptor, AKT, and some of these other receptors and downstream molecules. Again, all led to the approval of the three covalent BTK inhibitors we have in clinical practice: ibrutinib, acalabrutinib, zanubrutinib. We do know ibrutinib has fallen out of favor quite a bit within the US because of the availability of the two second-generation drugs and also the side effect profile of ibrutinib, which is typically a little bit harsher than what we see with acalabrutinib and zanubrutinib. So this is the sort of the timeline of BTK development. As you can see, beginning with ibrutinib's approval, we've had several BTK inhibitors approved over the last several years. And more specifically in other countries, we have other BTK inhibitors. So we have tirabrutinib, which was approved in Japan for primary CNS lymphoma, or orelabrutinib, which was a drug that was approved in China and had a breakthrough designation within the US. Clinically and sort of biologically, orelabrutinib is very similar to acalabrutinib and zanubrutinib, so not necessarily sure where this will fit into the US patient population. Tirabrutinib has specifically been focused on CNS lymphoma, so again, this might get an indication within the US for that patient population. But as we can see, in addition to single agent activity with these BTK inhibitors, we do see that these have been improved in combination, specifically in mantle cell lymphoma with bendamustine rituximab as part of the ECHO clinical trial, which did show progression-free survival benefit in that patient population. So again, the second generation drugs, as we mentioned, they have more fidelity to BTK, so less off-target side effects, so less interaction with TEC and ITK. So again, acalabrutinib and zanubrutinib are not felt to negatively impact T cells. Also, again, less rash, less GI toxicity, and again, less cardiac effects compared to what we see with ibrutinib in this patient population. Now, again, not in large cell lymphoma, we do see that acalabrutinib, zanubrutinib, have been compared directly to ibrutinib and shown to have at least a PFS benefit in this patient populations. Now, a lot of this is probably explained to just the fact that patients can stay on these second generation drugs longer than they can on ibrutinib due to toxicity profiles, because again, it doesn't make sense that at least clinically that these drugs will have different efficacy endpoints, but again, tolerability is likely the biggest driver of why we see progression-free survival differences between acalabrutinib, zanubrutinib, and ibrutinib in this patient population. As we mentioned, atrial arrhythmias are much higher in ibrutinib. We do know that there are undiagnosed and reported cases of ventricular events leading to sudden death with ibrutinib. We have had some reports about some events with acalabrutinib, but again, these have been few and small from one institution. We do know the BTK inhibitors with long-term use can help cause this blood pressure creep, where over time, patients' blood pressures will continue to increase up over time. And so that's something that you will have continued to monitor these patients. And all of these drugs can still cause arthralgias, diarrhea. Again, bleeding risk is much less with the second generation drugs. Pneumonitis is a risk just because of B cell receptor and sort of B cell suppression with these medications. And all of them do have some toxicity related discontinuation. Now, specifically looking at the cardiac events, it is likely a class effect and not necessarily specifically related to ibrutinib, because we do also see some cardiac events with the BTK degraders, which suggests that, again, even with the BTK degraders and the non-covalent BTK inhibitors such as pirtobrutinib, the fact that cardiac events are coming up suggests that it is likely a class effect and not specifically related to one drug. So the rationale for using BTK inhibitors in the ABC subtype of large cell lymphoma is that we do know BTK is a crucial downstream kinase of the B cell receptor, so it helps to turn off this receptor. So blocking this, again, would support shutting off a very important survival signal for these lymphomas. And again, germinal cell large cell lymphoma is characterized by the dependency of other ones such as SYK, PI3 kinase in a BTK independent manner, and BCL2 overexpression further promotes cell survival in a BTK agnostic fashion. So again, supporting the use of these BTK inhibitors in a select patient population. Now, the original studies that looked at ibrutinib in large cell lymphoma, if you look at this curve to the left, An overall response rate of 23% is not something to write home about. So again, it doesn't support that there is any kind of use of these medications in this disease setting. But if we segregate these into ABC versus germinal cell large cell lymphoma, you do say that an overall response rate is much improved in patients with an activated B cell subtype large cell lymphoma, with a overall response rate of 41% and a complete response rate of 17%. Again, if we look over to the right, germinal cell large cell lymphoma, only 5% of the patients had any kind of response, which was a partial response. Now, if we dive deeper into sort of biology-driven response, you can see with the CD79B mutant cases, you see a 71% overall response rate with 5 of 7 patients having a response. If we look at the CD79B wild type, again, a 34% response rate, so 10 of 29. And if you look at those who have a mutation in CD79B and NYD88, you see an 80% response rate, 4 out of 5. And conversely, if you look at those with a wild type CD979B and a mutant MD88, none of these patients responded, or patients who have a CARD11 mutation also lack a response. Because again, we do know a CARD11 mutation does inhere some resistance to BTK inhibitors, even in CLL and mantle cell lymphoma. So this sort of funnels us to the discussion we had earlier about sort of this slicing up the pie. As if you remember some of the subsets we discussed, such as MCD and the N1 subtype of large cell lymphoma. So the MCD subtype has NYD88 and CD79B alterations with carnal activation of the B cell signaling receptor. Also, N1 subtype of ABC has NOS1 mutations, which are also thought to be responsive to BTK inhibitors, where the BN2 subtype does not have any benefit from the BTK inhibitor, and the BCL2 mutation likely confers some resistance. So again, if we look at this in clinical practice, we would expect that those subtypes would be ones that we can target with BTK inhibitors, whereas the BN2 subtype would be a subtype we would likely look for another drug to add to our chart. So if some of you remember the Phoenix study, this was the randomized phase 3 study looking at ibrutinib plus R-CHOP versus R-CHOP in patients with non-germinal cell large cell lymphoma. There's a global study, was an attempt to see if we can integrate BTK inhibitors into the frontline space. So if you remember the key takeaway from this study, overall, there was not a significant progression-free survival benefit. So this was a negative study. But if we dove sort of deeper into sort of look at the differences, it appeared that the big difference between older and younger patients. So younger patients seem to have a progression-free survival benefit with the addition of ibrutinib. It seemed that older patients, again, because of dose discontinuations or intolerance or death due to the addition of the experimental agent, had a significant decline in progression-free survival and overall survival. And so again, that sort of drove sort of the negative readout of the trial as a whole, and sort of led to the sort of the lack of approval of this medication in the space. So again, here is the overall survival of the event-free survival of this patient population and intent to treat patient population. As you can see, there was no significant benefit. Even if you broke it apart into the ABC subtype, again, it appeared there was no benefit to the addition of ibrutinib to R-CHOP in this patient population. Overall response rate, again, 89.3% versus 93.1%. Complete response rate very similar between the two. CNS progression was noted in 10 patients in the ibrutinib arm and 16 in the placebo arm. Not a very significant difference, even though we know ibrutinib can cross the blood-brain barrier. And again, treatment emergent adverse events leading to discontinuation were mainly febrile neutropenia, mainly in elderly patient population and peripheral neuropathy. Now, again, if we look at patients, younger patients, patients younger than 60, and again, the argument I'm sure you can say 60 is not really old, but again, they have to figure out some sort of cutoff. You can see that there's an 11.1% difference in event-free survival with the addition of ibrutinib in this patient population, and a 12.3% difference in overall survival in this younger patient population, again, suggesting that there may be a little bit more than what met the eye as far as why this was a negative study, and potentially suggesting that there may be a patient population that may benefit from the addition of a BTK inhibitor in this patient space. And if we look at the hazard ratio here, this is about a 40% reduction in event-free survival and a 70% reduction in death with the addition of ibrutinib to the younger patient population. Now, the key takeaways from here is that if we look at the numbers of treatment emergent adverse events, grade 3 or above, or study drug related, they appear very similar between younger than 60 and older than 60. But we can see here there was a much higher rate of study drug related SAEs, treatment emergent SAEs leading to study drug discontinuation, or those leading to R-CHOP discontinuation. So again, it appeared that the addition of R-CHOP was impacting the ability to give R-CHOP in this patient population, which is fundamentally the most important part of the regimen. And so again, this probably led to some of the issues we saw with the event-free survival as a group as a whole, because again, these older patients, aren't necessarily finishing treatment. Again, we do know that their overall outcome will be impacted in the patient population as compared to patients who are just on R-CHOP alone, who are more likely to be able to finish the treatment course. And this is played out here. If we look at the ibrutinib R-CHOP arm in patients less than 60, as you can see that 93% of these patients received 6 cycles of R-CHOP, whereas in the patient population older than 60, you only had 73.7% of patients who were able to finish all the 6 cycles of therapy. And again, as I mentioned, the whole goal of this is that they have to be able to complete therapy to improve long-term outcomes. So again, the takeaway from here is that a lot of the issue wasn't probably that the design of the study was probably appropriate in some sense, but they didn't take into account a lot of the toxicity that came in these older patients when you combine ibrutinib to R-CHOP. It was not necessarily a very benign agent to add to this treatment for that patient population. And so if we look back again at the subsets that we discussed about before, NCD and N1, as you can see, this also played out to support that there was a substantial benefit in this younger patient population with the addition of ibrutinib. As you can see, the probability of survival, overall survival, again, so the EFS and overall survival in N1 and NCD, as you can see, when you add NCD patients with ibrutinib, it's substantially better than all of the categories, even the non-NCD patients with ibrutinib, or the NCD patients who got a placebo, or the non-NCD patients with a placebo. Again, suggesting again, if we could better select this patient population out, we can better apply this medication to hopefully improve outcomes across the board. Now, this will eventually sort of lead to some of the discussions we'll have about some of the upcoming clinical studies. And at some point, we will hopefully have a very large cooperative group study that will try to use a lymphomatch to try to better segregate these patients out, again, using some of this information to provide certain agents to certain patients based on their molecular subtypes. So again, the biggest takeaway, as I mentioned, is that, again, patients with these B-cell receptor-driven subtypes of large cell lymphoma appear to be benefit quite a bit from the addition of ibrutinib, especially younger patients. The patient population, what we would expect not to benefit, the BEN2 patient population, again, did not have any significant benefit from the addition of ibrutinib. So again, it sort of fits a growing hypothesis that, again, you can molecularly tease out some of these patients, and you can necessarily have a bigger sort of benefit when you add X, whatever X may be, to R-CHOP in this patient population. And so this has led to the ongoing phase 3 ESCALATE study, which is a phase 3 study looking at acalabrutinib in this patient population. So acalabrutinib being a second generation BTK inhibitor, the hope and thought is that this will have a better toxicity profile than ibrutinib. And so again, this is specifically, again, looking for patients with a non-germinal center large cell lymphoma. They will get a cycle of R-CHOP, and then it'll be, again, randomized into either acalabrutinib plus R-CHOP or R-CHOP plus placebo. And again, because this is a European design study, these patients will get another 2 cycles of rituximab at the end, cycle 7 and 8, as is the standard practice in Europe. And so this diagram here just sort of plays out and illustrates what we discussed in the last slide. So again, this study will hopefully read out at some point, so get another better look to see if there's a benefit to the addition of a BTK inhibitor in this patient space as of right now. So another study that they looked at with acalabrutinib is this window study. So in this window study, patients received 14 days of acalabrutinib, and based on whether they responded to acalabrutinib or not would determine whether they would continue acalabrutinib plus R-CHOP or just shift to R-CHOP alone. So as you can see from this waterfall plot, again, even with the non-germinal center, there are some patients who had significant dose reductions with acalabrutinib. Again, whether these are true GC patients or patients who are miscategorized, but again, nonetheless, these patients did have a response to acalabrutinib. And so if we look at the next slide here, if we look at all patients, the 2-year PFS was 84.8%. But by cell of origin, you can see germinal center patients had a 2-year PFS of 93.3%. Those who were responsive to a BTK inhibitor had a 100% 2-year PFS. The BTK resistant patients still had a PFS of 88.1%. And the PFS of those 2 categories are still higher than what we see with the non-GCB patients, which are the category you would typically expect to have the highest response rate to a BTK inhibitor, which does suggest in some ways that there's still more that we have to learn as far as sort of identifying patients and sort of picking out which drug they will be responsive to. So because of this data set, they did conduct a phase 2 remodel A trial, which is a calibreted plus R-CHOP in untreated patients with CD20 positive large cell lymphoma. So unlike the Escalate study, this study is taking all comers, not necessarily patients with non-germinal center large cell lymphoma. So again, we will wait to see how this study reads out to see if there's any benefit to a calibrated in patients even with germinal center large cell lymphoma. So shifting gears again to look at some of the other sort of strategies in frontline large cell lymphoma. Some of you may be aware of the SMART STOP study, which was a study that was conducted at MD Anderson. This was a study that basically gave a non-chemo lead-in to patients with large cell lymphoma and then subsequently shifted to add chemotherapy at that point to sort of estimate how much of a response patients can get in this patient population without the use of cytotoxic agents. So from this next slide here, we'll see that again, as you can see, with the addition of rituximab, lenalidomide, and ibrutinib, you do see that 36% of the patients were able to get a complete response with just this non-chemotherapeutic approach. With the addition of chemotherapy, you do see an improvement to 75%. And at the end of therapy, 94.5% of patients were able to obtain a complete response. And with this early readout, the 2-year PFS of 91.3%, and the 2-year overall survival of 96.6%. Now, the SMART START study has evolved into what we call the SMART START study. SMART STOP study, and what the situation, they're trying to see if they can reduce the number of cycles of cytotoxic chemotherapy. And so with this combination of lenalidomide, tafasitamab, rituximab, and acalabrutinib, with this 4-cycle lead-in, patients with a complete response will thereafter complete another 6 cycles of this combination plus 2 cycles of CHOP, whereas those who had a partial response or stable disease would then shift to just receive 6 cycles of of CHOP. So the goal of this is to see if you can sort of eliminate some of the risk that we know comes from the use of CHOP in this patient population. So those who get a complete response would have less exposure to the anthracycline, less exposure to the microtubule inhibitor. So hopefully decrease risk of cardiovascular events and cardiac toxicity, and increase risk of neuropathy in this patient population. So from this early readout, we know that at the end of therapy, the complete response rate was 100%. 47% of patients had a rash, 40% of patients had dose reduction with lenalidomide, which is to be fairly expected with this medication. And so again, this is leading to the trend that we may see coming up in the next several years, where we can hopefully move away from solely relying on chemotherapy for patients with large cell lymphoma, and we may have what we consider to be true chemotherapy-free induction regimens of patients with large cell lymphoma, with the hope that if they do not respond, they would still be salvageable with chemotherapy. And so looking at the swimmer's plot here, as you can see, a fair number of patients are still in remission. And then we have some patients that were still on treatment. And again, from what we know for some of the patients who had limited numbers of chemotherapy, there is data to suggest that these patients were still able to be salvaged with further cycles of chemotherapy with R-CHOP. Again, suggesting that we're not necessarily having any detrimental effect by not exposing these patients to chemotherapy at the beginning. And so again, this may be something that is explored in ongoing clinical trials in the future. So here are some other ongoing clinical trials looking at the potential of BTK inhibitors in older patients with large cell lymphoma. So we have the ACCEPT study, which is a calibreted R-CHOP. So again, this study is enrolled in 39 patients. The ACCRUE study, which is a calibreted rituximab without any chemotherapy, looking at 80 patients. The ARCH study, which is a calibreted R-mini-CHOP. This randomized study is enrolled in 330 patients. The ALLG study, which is a ibrutinib R-mini-CHOP, again, a phase 2 study looking at 80 patients. And then we have a study with zanubrutinib, polatuzumab, or rituximab. This study is a phase 2 study looking at the overall response rate after 6 cycles, which was 83%, at least from the interim data. Again, showing some of the exploration of some of these sort of modified treatment regimens for older patients to try to improve clinical outcomes. As I mentioned earlier, there are other several sort of clinical trials in this space looking at bispecific antibodies with or without chemotherapy as well. So again, hopefully we will have a better sort of treatment plan for older patients moving forward once some of these data sets eventually read out. So now we'll switch gears a bit and go through a couple of patient cases just to sort of see how we will apply some of this data that we've just recently reviewed to see how you would treat patients. So the first one is a patient NK. She's a 58-year-old woman with a past medical history noted for hyperlipidemia, hypothyroidism, and depression. All well controlled were presented with 2 months of progressive fatigue and unintentional weight loss, followed by 2 weeks of bilateral lower extremity edema. A Doppler does not reveal any venous thrombosis, but incidental bilateral immunoadenopathy measuring 4 to 5 centimeters. Subsequent CT scan demonstrated diffuse adenopathy above and below the diaphragm, a focal splenic lobe attenuated lesion, lung and liver lesions concerning for lymphoma. The biopsy of an axial lymph node revealed diffuse large B-cell lymphoma, CD20 positive, CD10 negative, CD5 negative, BCL2 negative, BCL6 negative, LUM1 positive, Ki67 of 80%. The FISH revealed no translocation of NACO BCL2. MRI of the brain and LP are normal. Labs had an elevated LDH of 580. So she comes into the clinic, and this is her PET scan, and she basically says she wants some advice on the clinical trials. And which of these clinical trials would you think would be most relevant to her specific case? So we have the randomized trial of R-CHOP with without venetoclax, which is the BCL2 inhibitor. Single arm study phase 2 of R-mini-CHOP plus zanubrutinib. The single arm phase 2 study of R-dose adjusted EPOC plus lenalidomide. The randomized trial of Polar R-CHP with or without acalabrutinib. And the randomized trial of R-CHOP versus R-CHOP plus high-dose methotrexate. So if you had this choice of options for this patient, which one of these clinical trials would you think would be most appropriate to offer her in this clinical situation? So a 58-year-old patient with what appears to be non-germinal center large cell lymphoma. I go with D. Right. So again, focusing in the fact that this is a non-germinal center variant and what we just recently discussed about the potential benefit of a BTK inhibitor, also the improvement in safety, which we would expect with acalabrutinib, we would expect that this would be the choice. So we do know from the studies that we have so far, looking at the BCL2 inhibitor, venetoclax, it appears to be most effective in patients who have very high expression of BCL2. Again, we do know also in the study looking at this in double hit lymphoma patients that is increased toxicity, especially neutropenia for patients when you add venetoclax to this chemotherapy backbone. Again, given the patient's age, she would not necessarily be a person you would consider R-mini-CHOP. She's 58, so she's young. So you wouldn't want to necessarily attenuate her doses of CHOP. Again, lenalidomide, unfortunately, thus far in the randomized study has not shown a benefit in large cell lymphoma. And again, there was also no benefit with R-dose adjusted EPOC in the randomized study versus R-CHOP in patients with a non-germinal center subtype. So adding this dose intensity does not seem to make a benefit in patients outside of patients with double hit lymphoma. And again, R-CHOP versus high-dose methotrexate, again, for the most part, there's really nothing that really supports the addition of high-dose methotrexate in frontline large cell lymphoma, other than, again, in patients where you are trying to promote some CNS prophylaxis, which, as I mentioned before, the data does not necessarily say that intervention necessarily will lead to a positive outcome. As again, the study that we have supports that there was no substantial decrease in CNS relapse, whether you gave methotrexate or not, in patients with high risk of CNS relapse. So toxicity considerations of BTK inhibitors. I'm sure all of us have used BTK inhibitors, so we know the major ones to expect. Cardiac toxicity, again, increased infection risk, cutaneous lesions, and muscle aches and joint aches that come with continuous use. And as I mentioned before, the creep of the blood pressure. So if we look at the RESONATE-2 study, Illuminate, A041202, ECOG 1912, and Elevate TN. So again, CLL studies, but what we can see consistently in this situation is that atrial fibrillation is a concern, especially with studies with ibrutinib. Arthralgias, again, appear to be a class effect because, again, it's not specifically associated with ibrutinib. Hematological toxicities, we do know occur with all of the BTK inhibitors. So if we look across the board, zanubrutinib probably has higher rates of neutropenia than acalabrutinib and ibrutinib, but they all can cause rates of neutropenia and thrombocytopenia in our patient population. Again, even though there's reduced risk, there's still bleeding risk with all the BTK inhibitors. Even if they have more fidelity to BTK, there's still some issues with their infected platelet binding. And as I mentioned, the blood pressure creep that we know with these medications with chronic use. And because of, again, the target of the mechanism, we do know we have B-cell inactivation with these medications. So again, patients are higher risk of viral infections, which leads to most of the infectious complications we see with BTK inhibitors. So we look at events of special interest. Again, as I mentioned, the clinical studies that compared ibrutinib to the second generation drugs, again, the biggest sort of readout from these is that these second generation drugs were still more tolerable. So you had a reduced risk of some of the more important adverse events that we see in this patient population. So AFib, a flutter, 13.3% versus 5.2%. Hemorrhage was about the same between the two, but major hemorrhage also equal. Hypertension was the same as I mentioned. Infectious complications, again, is a class effect. Neutropenia, as I mentioned before, is much higher, slightly higher, should I say, in zanubrutinib than we know with ibrutinib and acalabrutinib. Thrombocytopenia is the same, secondary malignancy is the same, and specifically skin cancer. So really, the biggest sort of difference between acalabrutinib and zanubrutinib really comes into the incidence and rates of atrial fibrillation. Now, when ibrutinib was the only agent we had, I'm pretty sure a lot of us had patients with AFib. We basically just managed it and still tried to keep the patient on ibrutinib. But again, faithfulness is always related to options. And so in this situation, since we have other options, for our patients, we're more willing to either bypass ibrutinib or switch very quickly when patients have toxicities, such as AFib with ibrutinib, which has led to a substantial decrease in the utilization of ibrutinib, at least within the US. So again, looking at adverse events of special interest, ibrutinib being the blue curves and ibrutinib being the orangish curve here. Again, as you can see, higher rates of these cardiac disorders, atrial fibrillation, flutter. Again, also VTAC and sudden death, higher rates of that have been reported with ibrutinib. So again, for this situation and this situation alone, ibrutinib, again, is not necessarily a preferred option in these patient populations versus the second generation drugs. So looking at all three agents together, as you can see, atrial fibrillation, again, higher with ibrutinib. Bleeding risk reported to be less with acalabrutinib, but as a whole, the bleeding risk is likely the same between these three drugs. Diarrhea, again, higher rates with ibrutinib than the other two second-generation agents. Hypertension, again, is blood pressure creep, again, reported to be higher than ibrutinib, with ibrutinib, sorry, versus acalabrutinib, zanubrutinib. Arthralgias, neutropenia, again, technically, like, again, most time you see more neutropenia with zanubrutinib than ibrutinib. Infection rates and thrombocytopenia. So again, to beat a dead horse here, we do know with the first generation ibrutinib, there are just more complications with side effects than what we see with zanubrutinib and acalabrutinib. And for the most part, this is why we choose these agents to use when we use BTK inhibitors, because they improve tolerance and the ability to keep our patients on these medications for longer. But if you do encounter these situations with adverse events, sort of what is your management strategy for patients? I mean, when you do dose reductions, how when do you monitor off therapy? When do you switch to an alternative BTK inhibitor? And when do you have to just abandon the class as a whole? So again, in the situation, we sort of classify these into sort of mild, moderate, and severe. Again, for mild situations, these are situations where you likely will monitor the patient without necessarily making a switch. For patients with moderate side effects, again, you will sometimes consider holds, dose reductions, and you specifically can consider in some situations, if you don't necessarily think it's a class effect side effect, to switch into an alternative agent. Where those are severe adverse events, you're likely going to want to switch to a different class of drugs. So this is just read out here. Again, with mild symptoms, if you have a patient with well-controlled atrial fibrillation, specifically, you probably can keep that patient on that BTK inhibitor, not necessarily switch. If you have a situation where your patient is having uncontrolled atrial fibrillation and the patient is on ibrutinib, again, this is a situation where you may consider switching to a second generation drug or switching to a different sort of alternative agent overall to avoid this toxicity. And again, if you have a patient with a ventricular event, you likely are going to want to switch to a different class of drugs overall. Or if your patient has a very severe cardiac history where they have a history of ventricular arrhythmias as a whole, you may not want to expose these patients to a BTK inhibitor and maybe want to look for an alternative medication. So looking at our second case, we have a 62-year-old Hispanic man with a past medical history of high blood pressure, dyslipidemia, type 2 diabetes, diagnosed with stage 4 IPI2, non-germinal sentinel cell lymphoma, and was being treated on a single-arm phase 2 clinical trial of acalabrutinib plus CHOP. His concurrent medications include long-acting metoprolol, atorvastatin, and metformin. Cycle 1 led to resolution of palpable peripheral adenopathy. He was symptomatically well controlled. However, his pulse is 74, but intermittently irregular, and EKG confirms new onset rate control atrial fibrillation without ischemic changes. He is currently asymptomatic. His echocardiogram confirms no change in his left ventricular ejection fraction. The laboratory analyses are unrevealing. CBC is improved with pre-cycle 1, thyroid studies are normal, cardiac enzymes are normal. His Apple Watch confirms consistent rate control. In addition to starting Navixaban and arranging prompt cardiology follow-up, you additionally recommend what for this patient? Continuing R-CHOP and acalabrutinib at current doses, holding the acalabrutinib and R-CHOP until cardiology clears and to resume at full dose, holding the acalabrutinib and R-CHOP until atrial fibrillation are resolved and restarting at reduced dose, removing ACS from the clinical trial and switching to zanubrutinib R-CHOP, or discontinuing acalabrutinib permanently. So with these sort of options, what would you think would be the best option for a patient who appears to have well-controlled atrial fibrillation without any sort of subsequent evidence of cardiac damage and his EKG and additional testing? Right. So again, this would be a person who would have a mild side effect. So again, the thought would be you will continue R-CHOP and acalabrutinib and just monitor the patient closely. And so again, the reason for not using holding the acalabrutinib R-CHOP until cardiology clears him to resume a full dose. Again, as we mentioned with the Phoenix study, we don't really want to delay R-CHOP in this situation. So again, if you had a situation where you needed to delay anything, you would hopefully delay just the experimental agent, which would be the acalabrutinib, and continue the patient on R-CHOP. Again, to make sure you ensure the patient gets to the appropriate treatment. Again, holding R-CHOP and the acalabrutinib until atrial fibrillation resolved and restarting to reduce dose. Again, delaying R-CHOP again is not in the best interest of the patient. And starting at reduced dose density compromises outcome in newly diagnosed large cell lymphoma. Again, based on his age, you would want to give him something such as mini-CHOP. Removing him from the clinical trial and switching to zanubrutinib. Again, zanubrutinib is not approved in this situation. And in this situation, the question is whether switching to a drug who has a very similar toxicity profile would make a difference. This may be a different answer if the patient was on ibrutinib plus R-CHOP. Maybe switching may reduce the risk of atrial fibrillation in this situation. But in this situation, the discussion between zanubrutinib and acalabrutinib has clinically not been shown to be any major difference between these drugs in efficacy or in side effect profile other than the rates of neutropenia. And discontinuing acalabrutinib permanently, again, this wouldn't be required because, again, the patient is only having mild adverse events. Again, if this is something he was having more severe consequences with, again, stopping the acalabrutinib would be more appropriate just to continue the patient on R-CHOP. So looking ahead, if you had to guess where you would utilize the BTK inhibitor in the management of your patients with large cell lymphoma, and are there any clinical scenarios in which you would consider implementing a BTK-based approach today? So this is with the understanding, obviously, that none of this is approved. But in a perfect scenario, like the old Walgreens commercials, if you have access to any drug to add to R-CHOP, is there any situation where you can see yourself adding a BTK inhibitor at this point, and for which patient population would you consider that for?
How about patients with primary CNS?
Yeah. So again, very good answer because in that situation, we do know the drug crossed the blood-brain barrier, and a lot of the data set supports, especially if patients fail high-dose methotrexate, this has been implemented at least into the second-line space, and a lot of studies are exploring these BTK inhibitors in the front-line space. And additionally, again, in a situation if you have a patient who has systemic and CNS disease at time of diagnosis, again, maybe allows you to give effective therapies at both and not necessarily compromise the R-CHOP. And then you can subsequently follow up high-dose methotrexate at a later point in time if they still had CNS involvement. Is there any other situations where you think you may use a BTK inhibitor for newly diagnosed patients with large cell lymphoma? I'm going to just leave some breadcrumbs. I'm sure they are leading to the situation of some of the data set with the non-germinal center large cell lymphoma patients. And if we ever, have the lymphomatch study readout, well, we can actually segregate these patients into some of these other subsets, such as MCD and N1. These would be situations where eventually, potentially, you would consider using the BTK inhibitor plus R-CHOP based on the results that we saw from the subset analysis from Phoenix. But again, as of today, again, very difficult to say where you would apply based on the clinical data that we have at current. We'll see how the Escalate study reads out to see if that fundamentally changes some of the situation that we have with the non-germinal center patients. But as I mentioned, with Frontline reading out and the EPCORE study reading out, we may have drugs that may be agnostic to cell of origin, which will really call into question some of the discussion we had about chopping up these patients into these smaller subgroups. All right, so at the end of the day, large cell lymphoma remains a heterogeneous disease. and which biologically informed treatment options are emerging. Maximizing cure in the frontline setting, we do know is the best option. Our best chance of cure is with frontline therapy, as we do even with CAR T therapy and other salvage options. We still only rescue about half of the patients who don't respond to frontline therapy. BTK inhibitors are an active and key biological subsets and are emerging option for newly diagnosed large cell lymphoma. And clinical and critical data from the pivotal studies such as Escalate are forthcoming, so we will stay tuned. As a whole, we will likely have 6 studies reading out with randomized options in frontline large cell lymphoma. So you may have a cornucopia of options to choose from. Whether that makes your day-to-day practice any easier, probably not, because again, then you have to tease through the data to figure out which regimen is best for which patient. And these studies thus far probably aren't going to give you necessarily the granular details to support which sort of category of patient or which presentation will be better than the rest. So with that, I'd like to thank you for your attention, and I will open up for questions.
Thank you for a great talk. Where do you use cDNA for minimal decisions? And after you finish 6 cycles of R-CHOP, which is positive, you go to CAR T cell.
Right. So, good question. I think as today, if we look at the available assays we have, so you have clonoSEQ and you have the Natera assay. I think the only time I would actually really put my faith in the results is if it's positive. The negative predictive value of these assays vary. Natera's assay may change since they bought Foresight and they'll integrate phase-seq, but that hasn't happened yet, so we'll still ways off from that. And even if we look at the transform data set that showed some ctDNA results between patients who were randomized to the standard of care arm versus CAR T, it still appears that there's some discordance between the positive predictive value as well, because as you saw, the ctDNA testing seemed to be very accurate when it looked at patients who went to CAR T, but the patients who were in remission and ctDNA undetectable that went under standard of care arm, there was a significant sort of relapse rate. So again, calling into question a lot of the faith we had put in phase-seq. Maybe it is not as sensitive as we thought for patients with large cell lymphoma. That being said, again, in my standard clinical practice, I'm not using ctDNA unless we have been participating in an allogene study where they are using ctDNA and then patients are randomized if they're positive to observation versus the AlloCAR product for consolidation. We'll wait to see if that's sort of a role for allogeneic CAR T cell therapy. But outside of that, I mean, just as I mentioned, because if it's negative, I don't believe it anyway. So in a situation, if I have concern about a patient clinically, we're going to follow them closely and likely salvage them with CAR or something else if and when they relapse. Now, the question is whether I can use ctDNA to take a patient to CAR T cell therapy. I'm likely not to get that approved because, again, when an insurance company sees that the patient has no evidence of disease, they're likely not to approve the CAR T cell therapy. And the ctDNA assays technically don't have a designation to allow us to make a treatment decision as of today. So we can gather this information and those patients, again, you'll follow more closely, but we don't really have anything that we can act upon at this point because, again, none of the clinical trials and none of the data that has explored ctDNA has actually used that as a trigger point to start another treatment other than this study looking at the allogeneic CAR T cell product from Allogene.
Do we have additional questions from the audience? All right, seeing none, thank you so much, Dr.
Thank you.